Hello, I am Dr. Venugopal, Head of the Department, Emergency Medicine, Malabar Institute of Medical Sciences, Calicut, India. This postgraduate level lecture is on detecting methods of endotracheal tube position. Objectives of this lecture include review of the conventional methods already available to position the endotracheal tube, to emphasize on good and gold standards as far as the tube position is concerned, and to review the international recommendations already placed as far as the tube position is concerned, and to propose an algorithm to tube position. Endotracheal intubation is a potential minefield for disaster. Errors in its performance can be associated with high morbidity and mortality for the patient and legal liability for the practitioner. Currently, there are many methods are available which can be classified into under three headings like observational verification methods, measured verification methods, and anatomical verification methods. What are the observation verification methods are available? These include direct intubation under direct vision, then observation of chest movement during or while providing ventilation, do the 5-point auscultation and to hear the breath sounds over the chest. Look at the sense of exhaled tidal volume, monitoring the compliance of reservoir bag, observing the tube condensation with the exhaled air. Again, look at the absence of gastric contents within the endotracheal tube. Measured verifications include end-tidal carbon dioxide and pulse oximeter. Anatomical verifications methods include esophageal detector device or EDD, chest radiograph, and lighted stilet. Also, sonological verification, fiber optic bronchoscope or laryngoscope, video assisted laryngoscope. Among the methods, different methods, all the methods are useful to confirm the tube position to a great extent. But all these methods are not totally free from problems. Every method has got its own merits and demerits. The direct visualization method is supposed to be one of the best and most reliable one, but it is also not free from troubles. Sometimes you may be totally fail to visualize that code at all during your intubation. Solve every possibility to dislodge the tube even before or after you are securing the tube. The inadvertent esophageal tube positions are quite possible even after direct vision intubation. This is one video to show the direct vision intubation. What about chest movements? Conventionally, we are looking at the chest movement to confirm the tube position, but sometimes in situations like obesity and lung diseases, the chest movements are either decreased or absent. And even sometimes an esophageal intubation does produce some degree of chest movement. Auscultation of axilla is also not totally free from trouble because And even an esophageal intubation can produce positive breath sounds in both axilla, and it may lead to misdiagnosis. Then conventionally we are recommending to auscultate over epigastrium to rule out the tube possession. Is it 100% reliable? Definitely not. It is also not 100% reliable. Especially, suppose your patient receive back, back mask ventilation, which cause an incidental inflation of inflation of gas stomach and gastric distension. This may sometimes cause the wrong uh, wrong idea of the two positions. End-tidal carbon dioxide detection, there are various methods like qualitative, quantitative, colorimetry, etc. This include capnometry, digital form, again the waveform format. Here is a video to show the carbon dioxide wave. These are the waveform, show the carbon dioxide form, end-tidal carbon dioxide waveform. This is a digital display. So 38 is the end-tidal carbon dioxide level in an intubated patient. As far as the end-tidal carbon dioxide detection is concerned, carbon dioxide in exhaled air confirm the tracheal tube position in patients with spontaneous circulation. Then what about patients? Then what about in patients with cardiac arrest, where apparently there is no spontaneous circulation, where also a level of carbon dioxide more than 2% will confirm the two positions. But remember, the absence of carbon dioxide will not rule out esophageal intubation. EtCO2 as a useful adjunct to confirm the tube position is supported by many studies with a high level of evidence. Level of evidence 1, 3, and 5. As far as end-tidal carbon dioxide detection is concerned, it has got a positive predictive value of 100%. A positive predictive value means endotracheal tube placements if the carbon dioxide is detected. And it also has got a negative predictive value of 20 to 100%. That means the esophageal intubation or esophageal tube placement if carbon dioxide is not detected. How much carbon dioxide is required to detect the tube position in the trachea? A threshold to detect 15 millimeter of mercury for a calorimetric capnometry is generally noticed. But if you are using a waveform or a waveform kind of capnograph, you can detect the tube position even a much lower level of carbon dioxide. The end-tidal carbon dioxide detection method is one of the most reliable methods. It is not the one of, this is the most reliable method to detect tube position. various studies shows that it is various studies shows that it is almost independent of users' experience. But EDT, entitled carbon dioxide detection, is also not totally free from trouble. Sometimes it may produce false negative reading also. A false negative reading means failure to detect carbon dioxide when tube is in the trachea. This usually is seen in patients with low blood flow and low carbon dioxide delivery situations, like in cardiopulmonary arrest and in patients on CPR, patients with pulmonary embolism, where blood flow is decreased to lung, a contaminated detector like with a gastric content and acidic drugs like epinephrine when administered through trachea, then false negative results continue. IV epinephrine sometimes will produce reduced elimination and detection of carbon dioxide glucose. Sometimes you will get a negative reading in severe airway obstruction, in status asthmaticus, and also in pulmonary Another wonderful device, the cheap device, is called EDD, that is esophageal detector device. The EDD is consists of a bulb that is compressed and attached to endotracheal tube, or a syringe attached to endotracheal tube. How does it work? What is the principle behind it? In the airway, there is a non-collapsible trachea and a collapsible esophagus. This is the anatomical base of using an EDD. When an EDD is fused and attached to the endotracheal tube like this, and when released, the suction created by the EDD will collapse the lumen of the esophagus and the bulb will not re-expand. But if the tube is in the trachea, the EDD will re-expand within less than 10 seconds.
This video will depict the use of the EID or EDD esophageal detector device. Patient's currently being ventilated. Intubation begins. Tube is placed, cuff is inflated, and the EDD will be squeezed and then placed onto the end of the tube. Quick recoil indicates it's in the trachea, proper placement, and bagging's continued. This ensures endotracheal tube placement in the trachea. Next step would be to apply end-tidal CO2, preferably using capnography.
The EDD sensitivity for esophageal tube positions is confirmed by different studies with a great level of evidences. The EDD are less specific as far as tracheal tube positions are concerned. We have the evidence at the level of 2 and 3 to support this. Esophageal detector devices are so highly sensitive for detection of esophageal intubation, and they have got a very poor specificity as far as the tracheal tube placement is concerned, and EDDs are not accurate for continuous monitoring. EDD will be misleading in certain conditions like morbid obesity, late pregnancy, status asthmaticus, copious endotracheal tube secretions, and tracheal tube collapse. The next equipment is pulse oximetry. Do you think pulse oximetry is useful to detect the tube positions? Certainly it is useful, but the results are usually delayed. The chest radiography is another method conventionally using to confirm the tube position, but the primary purpose is to ensure the position of the tube is below the cord and above the carina. This will never rule out an esophageal intubation or a tracheal intubation. Never confirm a tracheal intubation or rule out an esophageal intubation. If you want to do that, you should also go for a lateral film also along with its epifilm. Sonography is a new method to confirm the tube. Here it is a normal trachea with air in the trachea, and here is a tube is in the trachea. A lighter still is sometimes useful to detect the tube position in the fiber optic scope, video assisted laryngoscope are useful to confirm the tube position, but they are expensive and endoscopists or the laryngoscopists need experience as well. What are the international recommendations already placed as far as the tracheal intubation is concerned and tube positions is concerned? Emergency Medicine Journal in March 2001 placed their position statement. It states that independent confirmation of correct tube placement by use of devices that detect end-tidal carbon dioxide is mandatory for every tracheal intubation performed in emergency department and as part of the assessment of all patients who arrive at emergency department already intubated. American College of Emergency Physicians, that's the ASAP, in October 2001 placed their policy statement as far as the verification of endotracheal tube placements is concerned. This states that end-tidal carbon dioxide detection, either qualitative, quantitative, or continuous, is the most accurate and easily available method to monitor correct endotracheal tube position in patients who have adequate tissue perfusion. National Association of EMS Physicians placed their position statement in 1999. In their statement, in patients with a perfusing rhythm, end-tidal carbon dioxide detection is the best method for verification. American Heart Association, the protocol for advanced cardiac life support and their resuscitation guideline placed in 2002 and 2005 states that expired carbon dioxide detectors are very reliable in patients with a perfusing rhythm and are recommended to confirm the tube position in these patients. Association of Anesthetists of Great Britain and Ireland and American Society of Anesthesiologists, that is ASA, states that capnography is essential to the safe conduct of anesthesia, and the continual monitoring for the presence of expired carbon dioxide shall be performed unless invalidated by the nature of the patient, procedure, or equipment. NRP, that's a Neonatal Resuscitation Protocol guideline in 2006, and their consensus on science state that exhaled carbon dioxide detection is reliable indicator of ETT placement in infant, and it identifies esophageal intubation faster than clinical assessment. NRP recommended using exhaled carbon dioxide detection to confirm tracheal tube placement. Several international agencies and journals and experts recommend EDD, not EDD, ETCO2 is the method of choice to confirm the tube position. Then what about in the ground reality? There was a study conducted in US among the emergency physicians in hospitals, and these studies concluded that despite the recommendations issued by various national organizations that endorse continuous monitoring of end-tidal carbon dioxide for confirming ET tube placement, it is neither widely available nor consistently applied. This conduct, I suggest a practical approach and an algorithm to confirm the positions. So whenever you are intubated, try to intubate as far as possible under vision. After intubation, hold the tube and note down the tube marking at lip level. Then attach the ETCO2 detector and start ventilation. And look at the chest for an adequate chest raise. And then do a 5-point auscultation. Should start from epigastrium, then right axilla, right anterior step, and left anterior step. While the time this ETCO2 will be ready, and look at the ETCO2 for a color change or a waveform or a digital display. If it is positive, if there is a color change or a positive waveform or a digital display, yes, that tube means tube is in the correct position. If this is negative, obviously tube may not be in the trachea, where attach an EDD or esophageal detector device. This is to rule out an esophageal tube position. And if the EDD is not re-inflated within 10 seconds, means tube is in the esophagus, pull out the tube and re-intubate. If it is re-inflated within 10 seconds, that means tube is slightly in the trachea, but do a fiber optic confirmation for the and insert a fiber optic tube. If this shows the tracheal ring and carena, that means tube is in the correct position. If this is also negative, that means tube is in the wrong place. Take out and re-intubate. This is the complete algorithm for a confirmation of tube position. Intubate the patient under fusion as far as possible. Hold the tube and note down the marking. Attach the carbon dioxide detector or a capnograph and start ventilation. Look at for the chest raise. Then do the 5-point auscultation and look at the carbon dioxide detector or for a waveform color change or digital display. If it is positive, tube is in the correct position. If it is negative, tube is slightly in the esophagus. Attach an EDD. If the EDD is not re-inflated within 10 seconds, tube is in the esophagus, take out and re-intubate. And if it is re-inflated within 10 seconds, that means tube is in the trachea, but confirmed by using a fiber optic scope and insert the fiber optic scope. And if it is a tracheal ring or carena is seen, that tube is in the position. If it is not seen, take out and re-intubate. So, in conclusion, the confirmation of a proper tracheal tube placement is important. It is as important as a successful intubation. Axial carbon dioxide detection is reliable and should be considered the standard for confirmation of tracheal tube placement of endotracheal tube and for an early detection of an accidental intubation. Emergency physician should make sure the availability of ETCO2 detection devices in emergency room and with EMS team when they are in the field. They should also ensure the usage of confirmation of devices by concerned person. And thank you and thank you.